In recent years, and as early as fall 2025, neurokinin receptor antagonists have arrived on the market as non hormonal options for the treatment of vasomotor symptoms associated with menopause. Fezolinetant in May of 2023 and elinzanetant in October 2025.
There's a little bit of a difference between the two. The fezolinetant is an NK3 receptor antagonist, and elinzanetant is NK1 and NK3 receptor antagonist. And the difference, we believe that NK3 is mostly vasomotor symptom management. And the NK1 is probably has a little bit of an effect on vasodilatation, so can have an effect on hot flashes as well, but also has an effect on sleep through substance P. And so we think that elinzanetant may be a little more targeted to sleep specifically, in addition to vasomotor symptoms.
Emerging interest and research is now exploring how these NK receptor antagonists are playing a role in a large impact area of vasomotor symptoms sleep.
I think it's a benefit that elinzanetant has that dual receptor antagonism, and one that might specifically be related more to sleep. But again, many treatments for vasomotor symptoms, so it's not the only option. And I don't want women to think that that's the only option they have. But if a woman comes in and is having a lot of vasomotor symptoms and a sleep disturbance, and she's not a candidate for hormone therapy or chooses not to use hormone therapy, then elinzanetant would certainly be a great option.
So, when we consider menopausal sleep disturbances, the primary complaint that women report about is waking up after they've first fallen asleep, waking up and then having trouble going back to sleep. So, they're spending some time in the night waking and then spending that time awake instead of sleeping. So the Nirvana study really extends a lot of what we know about how elinzanetant is working in women who suffer from moderate to severe vasomotor symptoms associated with menopause. So there were previous studies that were the OASIS trials that showed very strong evidence that elinzanetant is very effective at improving sleep disturbances associated with menopause. And then Nirvana, what the goal there was to look at multimodal measures of sleep disturbance associated with menopause in women who had moderate to severe vasomotor symptoms to better understand how elinzanetant is working and looking at its efficacy, not just from the self-report measures, but also looking at our gold standard polysomnography sleep measures, as well as a novel device measurement of sleep that was used by the women when they were at home. So looking outside the lab and looking at very many nights across the time period when they were at home. And what Nirvana shows is that across all three measures, whether it was looking at self-reports or looking at the polysomnography, the gold standard sleep measures, or even that device placed next to the bed, is that elinzanetant across the 12-week period reduced wakefulness after sleep onset. So the sleep disturbance associated with menopause. So I think those results really confirm and extend what was known from the OASIS trials, that elinzanetant is effective at improving sleep disturbance.
When I'm really working with patients to figure out what the best option for them is in terms of hot flash sleep management, it's really patient preference. And so there are many patients who really feel strongly that they don't want to use hormone therapy for one reason or another. There are others that feel very strongly that they don't want to use an antidepressant. So sometimes it's what they don't want to use. Sometimes it is what seems most appealing in terms of ease. So I want a pill that I can take once a day, or I prefer a non-medication option. And there are plenty of those, including cognitive behavioral therapy, for example, has been proven useful for both vasomotor symptoms and for insomnia. So some women may actually prefer a non-medication option. So those are some of the things that we talk through. So it's a lot of what do they have any contraindications to the use of hormone therapy or any of the other treatments, including fezolinetant and elinzanetant? Do they mind having liver test monitoring, which is indicated for both fezolinetant and a little less for elinzanetant. It's baseline in 3 months for elinzanetant. For fezolinetant, it's baseline months 1, 2, 3, 6, and 9. So a little bit more in terms of liver test monitoring. So we walk through all of this and then say, what do you think the best option is for you? And this shared decision making is key here, because patients will only take what they feel comfortable taking, and what will actually work. And then let's not forget the importance of follow-up. So these women should be followed up in the 2 to 3 month period to figure out, is it working? In the case of hormone therapy, do we need to adjust the dose, et cetera?